All right, this is Physiology, and today I'm at University of New Mexico with Dr. Flavio de Castro. You can help me out with the second part?
It's Magalhaes.
Magalhaes?
Yes.
Okay. I see it in Portuguese, but I want to say it in Spanish.
That's right.
Yeah, okay. Well, Flavio, thanks for your time, and thanks for agreeing to talk with me. We're here at UNM, and you are assistant professor and lab director here at UNM.
Yes.
And so I'm always interested in finding out how people got interested in exercise science, exercise physiology, and in the research.
Mm-hmm.
So why don't you talk a little bit how you got interested in the field and also decided to go into academia and ultimately come to the US because you are from Brazil.
Brazil, yes. So yeah, I'm glad to be here. Thank you for the opportunity to talk to you, Kurt. So I think my interest in exercise in general began when I was about 5 or 6. I was put into soccer classes.
Okay.
And I got interested in sports at first, and then I practiced soccer until I was 14, 15 years old. And then after that, I had the opportunity to study abroad as an exchange student in New Zealand. I practiced rugby there, and while in that transition from teenager to that particular time in my life, I also got interested in resistance training. I don't really know why,
Mm-hmm.
but I was maybe 13, 14, and while I was in New Zealand practicing rugby, that kind of grew in me. Just I just wanted to practice it. When I went back to Brazil, I kept doing that. And I guess that interest in resistance training and understanding training per se was the reason that got me into. In Brazil, we have as here the physical education undergraduate course, but there sometimes it can be more related to what we see here as exercise science, not the physical education to be practiced at school.
Yeah.
But the name is physical education as well.
Mm-hmm.
So, and then as an undergrad student in physical education, I was always interested in training, understanding some of the basic mechanisms behind it. And then I think in my second year as an undergrad, I had exercise physiology as a class, and I just got into it.
Yeah.
I just found it very interesting to understand not only the acute responses, but how the body adapts over time.
Mm.
And then I think that was the foundation of my interest in exercise physiology.
Mm-hmm.
And then at some point, I became an intern in the lab with a scholarship in the exercise physiology lab back in the university that I graduated from. And then that, I think, I want to say naturally, drove me to after I graduated to the graduate school to do my master's, and I guess that all led me to here now.
Yeah. Okay. And so you completed your PhD in Brazil, and you got a faculty position there, and have decided to come up to the U.S. at UNM.
Yes.
And you've been here for how long?
I have been here now for 2 years.
Okay.
So the history behind that is that, yes, I was a faculty in Brazil, but another faculty here, you probably, I don't know if you mentioned him in other talks, but Fabiano Amorin, he was my PhD, my postdoc advisor but also when I became a faculty, we were colleagues back in Brazil. And as you know, he did his PhD here, so he had a connection to UNM, and then he at some point started working at UNM and left his position in Brazil. And then at some in 2019, he invited me to be or they all invited me. The faculty invited me to be a visiting professor for 1 year at UNM. So that got me into, let's put it this way, the UNM system.
Yeah.
And I was able to know how things were done here and how the lab was conducted and what kind of research in the facilities that UNM offered. And then I went back to Brazil back in 2020 to when I had completed my visiting contract here. I was back in Brazil with my regular position at the university, but then I got I applied to a position here at UNM, and then I've been here since June 2023, so almost 2 years now.
Yeah, okay. And currently you are studying diabetes and the effect of exercise on diabetes. So we'll talk about your specific work and also some of maybe the potential mechanisms that are involved with that. But I think a big thing of interest for a lot of people, not just students, but I think people that are interested in health in general, is how does diabetes develop? So from not just a pathophysiology perspective, but also from like a behavioral lifestyle perspective, how does diabetes develop? Because there's a thought of it's sugar, it's excess carbohydrates, it's ultra processed food that makes you diabetic and whatnot, but it is not that quite simple, correct?
Yeah, I don't think it's that simple. I believe that diabetes, we need to divide it into two big groups, or not too big, but two different clinical conditions. Type 1 diabetes and type 2 diabetes. There are other types of diabetes, but they're like clinically speaking or epidemiologically speaking very almost insignificant. So type 1 diabetes is not that well understood, but for some reason our own white cells in our blood for some reason attack the beta cells in the pancreas, killing them, making them ineffective in producing insulin. And this happens in a very short period of time, and again, there's not a very clear understanding of why that happens, this autoimmune disease. And that accounts for roughly 5% of the cases of diabetes.
How strong is that inheritability aspect? Is it very genetic?
For type 1, there is a genetic factor. It usually runs, it's more prevalent in families that have cases of type 1 diabetes. But then type 2 it has a much more clear genetic effect, but I'm going to touch on the environment stuff too. But type 1 only accounts for about 5% of the cases. So it's not, in terms of epidemiology, it's not the biggest issue that the society faces nowadays. Type 2 diabetes, on the other hand, accounts for 90-95% of the cases. And it is, in my opinion, a very good example of a combination of the genetic background must be there to some extent, but you need the environment to make that appear, that condition to show in a person. So I think one very good example of how genetics plays an important role is that it is very, very, very clear that the likelihood of developing type 2 diabetes is increased when you have a direct relative, mother, father, or sibling that has type 2 diabetes or lives with type 2 diabetes. And that risk increases as more relatives also have the condition. So just to give a number, the chance increases by a factor of 5 if a father or a mother or a sibling also lives with type 2 diabetes, and increases by a factor of 15 if two close relatives have type 2 diabetes. And just to give another number, it is around 2 to 3 times more likely to develop type 1 diabetes if a relative has it. So the genetic factor, statistically speaking, the genetic factor is stronger for type 2.
Yeah.
But at the same time, it is a disease that needs a proper environment, a bad environment, if you will, to develop. I think a good example that of how important the environment is. There's a specific Native American tribe originally from Arizona, that before the area was became part of the United States, was part of Mexico, and they're called the Pima Indians. That's the name of that particular Native American tribe. And when the United States conquered that particular area that is now Arizona, part of that population was originally left in Mexico, and part was now part of the United States. That happened like 100 years ago. So genetically, they have to be the same population, basically. Yeah. But the obesity prevalence in the Mexican Pima is around 10%, and type 2 diabetes prevalence is around 5%, or actually it's even lower, it's about 3 or 4%. The prevalence of type 2 diabetes in the American Pima that adopted the American lifestyle but with the same genetic background, the incidence of obesity is around 50% compared to the regular American, which is 35, around 40, between 45 and 40. So it's even higher than the rest of the American population. Yeah. And the incidence of diabetes, type 2 diabetes, is around 20%. So I think it's a very clear natural experiment that shows how important it is to have a certain genetic background, but the environment makes that boost, make that even more apparent. Yeah. So it is a disease that I think you need both genetic and environment to show.
And in terms of the environmental aspect, and for people, it's exercise or lack of exercise and diet. What is it about? Maybe not necessarily like the U.S. food, physical activity, environment, but what are those environmental factors or the lifestyle inputs that are going to increase the risk or increase the prevalence of type 2 diabetes, given whatever genetic risk someone may have, right? Is it the inactivity? Is it the diet, say, composition? Is it obesity? Is it specifically fat accumulation on the body, ectopic fat accumulation in different organs? Like, how do you sort of describe that?
Believe it or not, as you probably know, the mechanisms that lead to type 2 diabetes are not like completely teased out. Type 2 diabetes has a very, very close connection with obesity. But not all obesities are the same. Right. So especially obesity that is more related to, as you mentioned, ectopic accumulation of fat, which means accumulation where fat's not supposed to be at. So in visceral organs and organs in general, not in adipocytes where they're supposed to be accumulated. Right. And especially when that ectopic fat is accumulated in, as I just mentioned, in the visceral area, not in in other areas of the body. So that fat is accumulated around the waist, basically, not fat that is accumulated in the glute and in the thigh. So it's not 100% correct to say that, but usually the men phenotype is more related to accumulation of visceral fat, and the female phenotype more accumulation in thigh and glutes. But it's not. I don't want to sound.
So like one or the other.
Yeah, it's not like we have both.
Right.
Both genders accumulate in both sides, but
yeah.
So that particular accumulation of fat in ectopic fat, especially in the visceral area, is more associated with the development of type 2 diabetes. And what leads to the accumulation of fat in general? Yes, a hypercaloric diet and associated with a reduced physical activity levels that causes, let's put it this way, a caloric superavid.
Yeah.
That people then ingest more calories than they use, and that therefore leads to accumulation of fat. And for, again, reasons that we don't really know exactly, some people accumulate more fat in those areas, and that is more related to the development of type 2 diabetes. So I think I would not like to say that it is the diet or is the lack of physical activity. I think it's more a combination. And because when I mentioned previously that type 2 diabetes needs a genetic background, I don't mean one gene.
Yeah.
It's maybe dozens, maybe hundreds of genes combined that gives that person a higher likelihood of developing or not. So that being said, I also think that for some people, diet might be the biggest issue because their gene pool is more related to food handling and conserving energy. And for not other people, lack of physical activity might be the biggest issue. And I don't think our science is at that point to tease out what genes do what for type 2 diabetes. But there are research showing that there are some connections with some certain genotypes. But so I don't really know, to be very honest, which one is more important, and I think both depending, either one or both depending on the person.
Yeah. Even without having that specific, say, phenotype or genotype understanding of a specific individual of what should they focus on the diet aspect, or are they more susceptible to the diet aspect or more susceptible to the physical and activity aspect. One, being physically active on the whole is going to be beneficial for everyone, regardless of genotype. As is, not having a hypercaloric diet, right? And so, maybe one thing to highlight, irrespective of what someone might be more susceptible to the diet or the inactivity aspect, but being lean, or at least not being overweight or obese, right? That would have a huge impact in terms of reducing the risk of development of type 2 diabetes, correct?
I would think strongly so, yes. So not being overweight or obese is a strong predictor of not developing type 2 diabetes. However, exercise, I think this is very important to mention. Exercise, let's put it this way, being physically active for regularly, exercise training, if you will, is effective regardless of weight loss.
Right.
It's not because it's not, in terms of developing or not type 2 diabetes, it's not because exercise makes usually people lose weight when they're done regularly. It's not that factor per se itself that prevents the development of type 2 diabetes, because there are examples of people that do not lose weight, do not lose fat mass performing exercise, and they have better blood markers, insulin resistance, A1C levels, compared to people with that same fat mass that are physically inactive or insufficiently active.
Right. Yeah.
So I think it's important that exercise acts in both ends.
Yeah.
It helps to lose weight, which is awesome, which is very, very good. But it also has a exercise effect, regardless of weight loss or not. So I think that's very important to appreciate and to have to understand that exercise is not because it makes you lose weight specifically. So I think that's it's good for us from exercise science to know that and to appreciate that side of exercise as well.
Yeah, no, that's a good point. I'm glad you make that point, and that's a point I make with my students in talking about obesity and risk of chronic disease like type 2 diabetes, like you mentioned. Exercise has a huge beneficial effect on type 2 diabetes prevention or management and improvement of symptoms, and also other chronic conditions as well, irrespective of weight loss. And from a practical standpoint, for example, if someone's working with someone who is overweight or obese and they do want to lose weight but they just want to get healthier, that if they're exercising regularly, like you say, but they're not seeing a change on the scale, that doesn't mean that they wasted their time. They're still getting a huge benefit out of that regular exercise.
Of course.
Yeah.
Yeah, I totally agree with that.
Yeah.
Yes. And what I have seen particularly in my research, which I think we're going to get there, is related to, at this point in my research line, we explored the effects of resistance exercise and training on glucose metabolism. So associating resistance exercise on people that live with either pre-diabetes or type 2 diabetes. And we see that we see improvement in the markers of for people with pre-diabetes, the markers that make them progress or not to type 2, and with people with type 2 we see improvements in those markers as well, even if they don't lose fat.
Right.
If it doesn't change on the scale. Another interesting point that I try to highlight every single time with the participants from the research is that because we are doing resistance training, sometimes they get a little concerned that from 1 month to the other they see an increase in weight on the scale.
Yeah.
And they say, well, this is not working, actually it's making me worse.
Yeah.
And then because we do also body composition assessment, I can prove to them, look what's happening. Yeah, you are gaining weight. Doesn't happen to everyone, but for most of the ones that do, it's mostly lean mass that they are gaining, and it's kind of a side effect from resistance training. So it's an example that the scale is not the best, parameter to follow the progression of resistance training. Especially that when people have in their minds, which is correct in most cases, that when they see a higher number on the scale means that they gain weight in fat, which might not be the case for resistance training. So we do see that. We see people that don't lose fat that we are observing improvement in them, and we see people that gain weight mostly in lean mass, also some observe improvement in them, and I think full disclosure, there are some people that do not improve. So, and this is something that we have been interested, and I think has a lot of practical implication, is that we do have non-responders. We have non-responders, we have low responders, we have high responders. Yeah. One thing that we have been trying to study and evaluate is a person that is a non-respondent to that particular prescription. Is that person doomed and doesn't respond to exercise? Or can we change the prescription, maybe increase volume, maybe increase load, maybe increase number of reps, or maybe change the prescription a little bit, and then will this person respond? So we're trying to understand that a little bit better, because again, I think it has a lot of practical implications, because when you do exercise, especially when exercising for health, you want to see improvement. I mean, exercise for any reason. You want to see improvements.
Yeah.
And then you exercise for 3, 4, 5 months, and sometimes no improvement.
Mm-hmm.
So what I'm doing wrong? This can be very demotivating.
Yeah.
Can be very, people say, I'm just gonna put that aside because I'm not an exerciser.
Yeah.
By default.
Mm-hmm.
And what we are exploring is that maybe the person is not a respondent to that particular prescription. So it's not that they're doomed. So we're testing that. Other groups around the world also interested in testing that. And so that's kind of what we have been doing as well.
Okay. I'll follow up with much more questions on that specific area and your line of research on that. But I do want to ask a little bit more on, say, the development and progression of type 2 diabetes. So, for example, there is a thought that type 2 diabetes, insulin resistance, is caused by high blood glucose levels rather than the chronically elevated blood glucose levels are a consequence of the development of insulin resistance and the type 2 diabetes. Can you speak to a little bit of that? Because that brings in the whole idea. I was talking to a couple of people here, a couple of students about it, of like wearing CGMs for someone who is, metabolically healthy, doesn't have any sort of insulin resistance, their A1C is fine, like they have no problem with their glycemic control, but an obsession with trying to keep your blood glucose levels low or not have, a spike, because the thought is if that does happen, that's going to cause, one, obesity, so people think that, and then also that's going to contribute to the development of diabetes. When it's more like the chronically elevated high blood glucose levels are a consequence of that development of that pathophysiology. Right.
So I think we need to understand that glucose levels are regulated by two things. Glucose production, be that production by the liver or by the gut. Let's call that production, so the glucose that ingests and ends up in your bloodstream, and glucose uptake, especially the glucose production in the liver, and glucose uptake, especially by skeletal muscle and adipose tissue, is dictated by, or is influenced, is modulated by insulin, by the amount of insulin we have it's produced and we have in our blood. So I believe the most accepted model of the history of the disease is that the excess, the accumulation of fat. There are some mechanisms that are that can explain that, but the accumulation of fat acts on many tissues, but three main ones. It messes up with glucose metabolism in the muscle, glucose metabolism in the adipose tissue, in the fat tissue, and in the liver. And in all three of these tissues, this accumulation of fat, this dysregulation of fat metabolism, the ectopic accumulation of fat, for different mechanisms, it leads to insulin resistance. So that model dictates that you don't need to have a high glucose levels to begin with to develop the conditions. The condition is dictated by this accumulation of ectopic fat leading to insulin resistance. So given that we have insulin resistance, say, in the muscle, and insulin in the muscle makes the muscle uptake glucose. So if insulin resistance is developing, and it's a long-term thing, it's not like overnight.
Right.
This is developing. The muscle is uptaking, or let's put it this way, the muscle needs more insulin to uptake the same amount of glucose. So glucose levels are normal, euglycemia. So the pancreas must be more activated in this scenario to produce more insulin. So insulin levels are high, and the muscle then uptakes more glucose. The same thing with the adipose tissue.
Yeah.
To understand the glucose level, you need to understand glucose uptake by some organs and glucose production. Glucose production is basically dictated by how much our liver produces glucose. And glucose uptake is dictated by how much glucose our muscles and the adipose tissue is able to uptake that glucose. And for those two things, production and uptake, insulin plays an integral part. In the liver, insulin inhibits glucose production, so it stops the liver from producing glucose. And in the muscle and adipose tissue, insulin stimulates glucose uptake. When people have accumulated fat, especially ectopic fat in the visceral area, this leads to this compromises glucose metabolism in those three tissues. In the liver, this accumulation of fat leads to insulin resistance, which makes the liver less responsive to insulin. Therefore, when insulin is supposed to inhibit glucose production by the liver, it doesn't as well. So for a given insulin amount, concentration, the liver will produce more glucose compared to an insulin sensitive state. And in the muscle and adipose tissue is pretty much the same understanding of how insulin resistance works. The accumulation of fat, the ectopic fat, it causes insulin resistance. Therefore, we need more insulin for the muscle and adipose tissue to uptake more or the same amount of glucose. And the organ that produces insulin is the pancreas, the beta cells in the pancreas. So when a state of insulin resistant in the liver, muscle and adipose tissue it happens, the pancreas must produce more insulin. So as the pancreas produces more insulin and the muscles and adipose tissue and liver continue to develop insulin resistance, at some point the pancreas won't be able to keep up with that amount of insulin production. It just doesn't have the capacity to produce insulin forever, or on that amount forever. This means that at some point this state of insulin resistance will lead to hyperglycemia, will lead to high glucose levels, not because high glucose levels were the cause of weren't initiating the whole issue. So insulin resistance, high insulin levels, the inability of the pancreas to keep up with that amount of insulin production, that will eventually drive glucose levels to a high, to a high number, and this will at some point be clinically understood as either pre-diabetes or type 2 diabetes.
Yeah, and the main driver, at least in this model, is the ectopic fat accumulation that is going to drive the insulin resistance at those multiple tissues that will lead to higher blood glucose levels because of that insulin resistance and the inability to manage blood glucose, especially coming from the liver.
Yes.
Yeah.
Exactly. So it is, insulin resistance is the first step toward type 2 diabetes.
Yeah.
And insulin resistance is caused by it's most likely explained by the accumulation of ectopic fat. So ectopic fat kind of is the driver of the whole thing. And then this leads to insulin resistance. Insulin resistance leads to high glucose levels, which eventually will be clinically characterized by either pre or further in type 2 diabetes.
Right. And so the focus of trying to keep, for example, like a lot of people say on podcasts and social media, of keeping your blood glucose low or preventing spikes, like with through food, right? That is not something that someone should try to focus on, because it is not a causal factor of type 2 diabetes or insulin resistance or even obesity and
Yes.
fat accumulation.
Yes. So glucose spikes are natural things if you ingest a high sugar food, and the most accepted model for insulin resistance type 2 diabetes does not take into consideration glucose spikes in your blood that would contribute to the development of type 2 diabetes. Too much sugar in the diet, it is associated with obesity, but it's not the spike in sugar that drives type 2 diabetes.
Right.
So ingesting a high sugar meal or snack once in a while, it's not the issue. It's not the big issue. So the issue is when those snacks, those repeated meals are high sugar, high fat, high caloric, and lead to obesity, and obesity then leads to insulin resistance, and this drives glucose levels up.
Right.
After the person develops type 2 diabetes, then they should avoid high sugar meals anyway, because the body now has a hard time dealing with lots of glucose in the circulation. So they should avoid that for that reason, but not to prevent someone that doesn't live with type 2, to prevent developing type 2. The sugar spikes in the blood are not a causal factor of the condition.
Right. Yeah, there's, I don't know if you've seen this, but there's a whole sort of thing of wearing CGMs, continuous glucose monitors, for people that are, don't have insulin resistance or type 2 diabetes. But the idea is to monitor to keep your glucose levels low and to prevent a spike. But, as you mentioned, that's not something that, for someone who does not have those conditions, type 2 diabetes, is not really useful information to really reflect any sort of thing.
Honestly, if someone does not have an alteration in either fasting glucose levels, I think wearing a CGM is not only gonna not provide any valuable information, but it's also can be very costly.
Yeah.
And you only can get that with a prescription, and even then, I think it's gonna cost some money to wear it. So, I do not think having a CGM inserted on you, if you don't have, altered glucose levels to begin with, I don't think that will help you in anything,
right.
Basically.
Well, let's get to your specific research. You alluded to it a little bit, but you are looking specifically at resistance exercise, at least right now, right? Resistance exercise and the effect of resistance exercise on markers of blood glucose or blood glucose control in type 2 diabetics, and then also kind of looking into responders versus non-responders, and if someone is not responding, what could we tweak in order to make that person get the benefits that we're looking for from an exercise program.
Yes. So, my research right now is focused on understanding how different prescriptions of resistance exercise can affect your glycemic control or the glycemic control of people with either pre or type 2 diabetes. But also something that I'm not, it's not our primary outcome, but I'm also interested in the psychological responses to those prescriptions. Because say, for example, that a high intensity resistance exercise prescription, which might lead to high levels of effort, high levels of muscle soreness, high levels of discomfort during the session, let's say that this particular prescription is good to improve your glycemic control. What if we are able to prescribe the same amount, the same volume, but with lower loads, maybe tweaking rest interval or something else, that we can also get benefits from in that particular population, but with lower levels of effort, lower levels of soreness, or lower levels or demotivation in general. So I'm trying to look at that as well. So how can we make the prescription more attractive while maintaining its effectiveness? So that is one big thing that we are studying right now. The other, which also I'm very, very interested, and it runs in parallel basically, is the responder versus non-responder versus negative responders, high responders. We are trying to see if we are able to identify a person that will respond to a particular prescription if they, given their baseline characteristics and given the response they have to one session. So we want to see if what they show, how they improve or not in the long term, in 4 to 5 months into the program, can be predicted to some extent by either baseline or one session of intervention. Why is that? Because I think that people in general, epidemiologically speaking, about less than 30% of people are physically active in the sense of do what they're supposed, what's recommended to do. And when people with especially pre-diabetes and type 2 diabetes, they engage in exercise, they are usually, I'm not trying to make profiles here, but usually there are people that are not used to exercise that much. So would they have to wait 3, 4, 5, 6 months to see if they are responsive to that particular prescription? That can be very, it can compromise the motivation to engage in exercise, because you can say, well, you might get better, or you might not. You might get a lot better, or just a little better, or you might get not any benefit at all. So what if you can not predict with 100%, but we can at least have some prediction that given the responses to one session, or even the baseline, characteristics that they have, we could predict to some extent how they would respond. I think this would not only make people more motivated to exercise, but it would also help us as the professionals prescribing the exercise to be more to the point. So I think that it carries a lot of practical implication. If we could, I don't know if you can, I don't know, but if we could say, well, given that particular profile that I have in my hand and the response to one session, it's better if that person follows that prescription, not that one. So that's something I'm really, really interested in. And again, I think it carries practical implication to the general public. You're getting, instead of waiting 3, 4, 5 months for a feedback of I'm doing something right, you can get it more immediate, and like you're mentioning, keep people motivated. Right? And if it's not what we would want to see, then it gives a professional an opportunity to modify the prescription. Right? Exactly. And so specifically, when you say looking at an acute response, what is the measure that you are looking at to determine or to discern that? Right. So we just mentioned the CGM. And the CGM is a very powerful, capable device that measures glucose levels it's minimally invasive. It's in your skin. It's not even in your blood vessel. It's in your skin. And it measures glucose levels depending on the model, every 5 or 10 minutes for a certain period of time. So 10 or 14 days, again, depending on the model. So if you imagine how many finger pricks that would mean, it's very powerful for that.
Mm-hmm.
It's minimally invasive. Person doesn't even realize they're wearing it after some hours, and it gives us a lot of information. But again, it is more suitable for people with already dysregulated glucose levels. So we do make use of the CGM to explore the acute responses. So we ask the people to wear the CGM for a certain period of time, either controlling or not their diet. We do that by design, and see in the day of exercise, the day after exercise, in a non-exercise day, in the weekend. All these days are different diet-wise and physical activity-wise. So we see when did the person, if they responded, when was the response more clear, and always comparing to a non-exercise data. So it is how much, basically the glucose levels from the CGM that we assess.
Mm-hmm.
The CGM itself, we have, I don't want to say dozens, but definitely more than 10 parameters. It's not only average glucose over a day. It's not only that. We can extract a lot of information, and based on that, there's even calculations that can predict from the CGM, from those 10, 14 days, what would the A1C levels be in the long run.
Okay.
So it's very informative for that. But again, it only kind of works in people that have dysregulated, impaired glucose levels.
Yeah.
Because it wouldn't show much in someone that has euglycemia, basically.
Yeah.
So the acute effect is based on the CGM outcomes.
And you're currently collecting that data right now.
We are currently collecting that data right now. Yes.
Yeah.
So we have we collect that. We have a 6-month intervention. The first month or so is more to get the person familiarized with exercises, and then they go over several different prescriptions of resistance exercise, keeping two important things, some important things: the same exercises, obviously, the same volume load, so the same amount of basically work performed in the session, in the same amount of time. So session duration is clamped at around 45 to 50 minutes, and total volume load, meaning the amount of pounds lifted, is the same in the session, given regardless of if it's high load, moderate load, low load, whatever precision we use, because then we would be biased, right? If we change some of these parameters. So they perform these sessions. We see how much the glucose levels change in the CGM, and then they are randomized to one possibility of long-term prescription. They do a certain prescription then for several months, for 4 months basically. Mm-hmm. And then we can see if the change that we observed in the long term for that particular prescription, does it correlate, does it associate with one of the acute responses that we observed?
Yeah.
So by design, we are going to have people that responded acutely well to a particular prescription, that were put in an exercise training prescription that they don't respond to by design.
Yeah.
And we're going to have people that responded and were put in the group that, in the training prescription, that we would anticipate they would respond.
Mm-hmm.
and the other way around too. Have people that did not respond, and by design were put in the non-responsive prescription, or didn't respond, were put in. Well, we have many possibilities, and we're kind of exploring at this point. We don't really have. I do have a hypothesis, but it's more exploratory at this point. To see if we retrospectively, given the changes we see after 4 to 5 to 6 months, if we can associate that with something that we saw in the beginning.
Yeah.
And then, as any research, we don't really know
Yeah.
what the outcome will be. But regardless of the outcome, I think that it's going to carry some practical implications. Even if we say, well, we couldn't predict.
Right.
We couldn't predict.
Yeah.
So we do have to try it out by, play by ear, basically.
Yeah.
And but one thing that I want to do in the future is intentionally put someone in a group that we don't think they will respond, train them for 4 months, see if they actually did not respond, and the hypothesis that they would not respond, and then change them to the responsive group, right? So by design, have them 4 months in a group that they wouldn't respond, and then change them to see, and the other way around too.
Right.
They could begin in the responsive group, and then be changed to the non-responsive group to kind of proof of concept, I guess, to see if our hypothesis is correct, or if it's just it is at this point just randomly people respond or not. So that's where we are at this moment in our research.
You had described this to me last week when I got here, and that is a super novel idea and super novel design, not just from like a scientific design standpoint, but like you mentioned, like from a practical perspective, like that would be a very, very powerful tool for practitioners that are working with individuals that have insulin resistance or type 2 diabetes to check, would my programming be effective for this individual given their acute response?
Yes.
Yeah. So
yes.
That's very cool.
Yeah, and I think all this is important because there's a lot of evidence that for glycemic control, I want to be very careful with the words I use here, but we don't really have a chronic adaptation. It's not something that changes in the body with exercise that makes our glucose levels better.
Right.
It is the daily, the session. It is the session. It is the session that reduces glucose levels, and then you reduce it again with this next session, and then 2 days later again, and then 2 days later again, and then and that constant up and down or down and of the glucose levels, that is the mechanism that exercise, let's put it this way, has to improve your glucose levels. Different from hypertrophy, for example. Different from increasing the number of oxidative enzymes with endurance training, which is something chronic. Apparently for glucose control, there's nothing that changes in the body that responds, that is responsible for changing the glucose level. It is the daily thing. It is the daily thing. So that's why the hypothesis is, well, if we can identify someone in one session, we might be able to say, if they responded to that one session, if we do that over several weeks, days, months, they might have lower A1C by the end of the 4-6 months.
It's the repeated acute effects.
Repeated acute effects. I think that is the key to understand. And again, I think there is overwhelming evidence to that, even though there are some also evidence to associate improvement of glucose glycemic control with mitochondrial adaptations. There's evidence or suggestions that glycemic control might be associated with larger muscle mass, but I think there are more evidence to pointing toward the fact that it is the acute repeated effect rather than something that accrues with training.
Yeah. Well, you might have, long term more GLUT4 proteins, but you got to activate them, right?
Exactly.
Yeah. So it does come down to that acute, the acute response.
Yeah, and the acute response is not that you should, for training purposes. I think in the theory of training, of exercise training, the stimulus must also increase over time.
Yeah. Right.
So if you have a certain, if the stimulus is increasing over time, more GLUT4 will be activated or be anchored to the membrane, and then more glucose will be uptaken by the muscle. So, but again, I think there is evidence enough to convince me, at least, that it is the acute effect.
Yeah.
It is the acute effect that counts. So that being said, we also in the future want to test. What if we have the same? Let's put it this way: the same weekly volume spread every day, because usually what we do here is twice a week. We do the traditional twice a week whole body intervention. Can we spread that every day of the week, just a little bit every day? And the other end of the spectrum will also be tested. Can we just split that in one day just to get it done? And people, just let's be done with it for one day.
Right.
So again, I think that what I'm trying to explore is to give people more options. Because I think when it comes to health, the default choice is always aerobic training. Always. Walking, running, swimming, cycling. People think of resistance training more to, bulk up. Just to get more muscles or related to more, or related to sports performance. Like, which it is,
right.
Which it is.
Yeah.
But I think that for the last, I want to say 15, maybe 20 to 15 years, the literature on the resistance training being used for health purposes has grown, but it's still, we don't still have enough information as we do for aerobic exercise. So it's the information is not out there yet for the public in general. And what I think where I think I fit is to try to produce information that people can choose resistance training if they want to.
Your main goal from the research, your research, is you're providing options, right? Showing that not just aerobic, which, like you mentioned, there's decades and decades of research, and there's decades of research that resistance training on health, like overall, but especially with type 2 diabetes, has to kind of catch up with, because there's comparatively way more aerobic data, like you mentioned, right? But your sort of research end goal, or the use case for it, is providing options for people to use and employ, or practitioners to be able to use and employ for the specific reasons of preventing, managing type 2 diabetes and improving blood glucose control.
Yes.
Yeah.
That would be my ultimate goal, yes. And I think things that I did not anticipate before I started, studying and having the opportunity, and actually I'm very lucky to have the opportunity to work with the participants myself, like, in person, is that honestly, I think for some of them, resistance exercise is maybe the only option. To exercise, because some of them have serious, not serious, but knee issues that would prevent them from long walks. Others have, some of our patients, they they use like knee braces, and some have a hard time, just getting around.
Right.
So obviously this can get in the way of resistance training, but we found a way around it. Like, sometimes we just change the prescription a little bit to suit that particular participant. But there are many participants that's not what we studied. That's only anecdotal, like just from observations, not scientifically speaking, but that I do not visualize doing something else than some type of stationary resistance exercise, instead of something more cyclic and that would stress too much one particular joint. So, but again, I think that given that maybe let's say that both types of exercise are equally effective or comparably effective, that type of information must be publicized and out there, so people know that, well, I don't have to walk if I want to be healthier. I'm not stuck to that. I hate walking, whatever. I have options. And then again, within the resistance exercise area, we're even trying to go a little bit deeper to see if we have different options in the resistance exercise. Because again, I think that sometimes the high intensity, high load, high effort prescriptions are not the most attractive ones for everyone. It might be for us, we like it, we wanna, but for some people might not enjoy doing that much. So are they able to do resistance exercise, improve their glucose levels, and not that be an excruciating experience? So that's where the options come into place. That I'm trying to explore those options in the resistance exercise area.
No, I think that one is super useful and practical, and also social media podcasts, right? There's a lot of do this specific workout, right? Do this specific protocol, and when in reality, kind of like what you're getting at, no, there are a lot of different options that one could employ, one could use, right? And I think the like to your last point, what is really useful is, someone might listen to one of these optimal biohacker protocols, do this specific exercise, but they can't for whatever musculoskeletal reason or whatever particular physical limitation that they might have, and that might completely discourage them, right? And be like, well, there's no hope for me because I can't do this workout, right? But like you mentioned, publicizing, providing options that people can use and employ, or practitioners can use and employ to achieve their health, fitness goals is hugely important, right? And it's not just this one simple trick protocol that you have to do, and if not, well, you're just wasting your time, right? Okay.
Yeah, that's the idea.
I think I mentioned to you that we're doing a creatine glycemic control study in healthy young adults, right? So different population, but maybe that's something we can collaborate on to see what our creatine data look like.
I think creatine is very interesting because it's not a particularly expensive supplement. It's a supplement that has minimal side effects, like the most common one, like water retention. So what, right? The actual hard literature doesn't show any kidney issue, doesn't show any liver issue. So there's a lot of myths surrounding supplements at all, and creatine is not an exempt from that. So I have read some of the literature regarding creatine and glycemic control, and I think there's definitely something to be explored there. I find it very interesting.
Yeah, definitely. All right. Well, I have one last question for you. What's the story with the sleeve? I'm interested.
So, as I mentioned in the beginning, I lived in New Zealand for a while. I was 15, 16 years old, but they have a very strong. The natives there, they have a very strong culture. It's called the Maoris. The Maoris, they are natives from the Pacific Islands, and New Zealand is one of those Pacific Islands. And they have a very strong culture, and part of the culture is related to tattoos. They even tattoo their faces to enhance their facial expressions, and so this is a Maori tattoo, and each part of it represents a certain aspect of their culture. I won't lie that I know all of it, but I have investigated back then, and each part of it represents something, or an individual, or a milestone, or something related to hunting and fishing. They're very connected to the sea for obvious reasons, or they're used to be not particularly now, but they used to be warriors defending their land, so it also relates to that. So I just wanted to have a tattoo that represented and that marked that particular time in my life. That was very important for me to have that experience and maybe honor them in a way on my skin.
Yeah. Did you get it done all in one time?
You mean one sitting?
Yeah.
No.
Oh, okay. Yeah.
It goes all the way to the back as well.
Oh wow. Okay.
So altogether, I want to say, maybe 10 sessions.
Yeah.
It took a while.
Yeah. Yeah.
Maybe a year altogether.
Yeah. Yeah.
Back-to-back sessions.
Well, I have two here and then here, and I actually got them when I was doing my PhD here. I got them done right over here.
Oh, that's nice.
Yeah, next to my barber shop. So these, like yours, represent a specific time in my life.
Yeah.
And just like coming back here, reminding me of that time.
Yeah.
So with that, Flavio, thank you for your time. I enjoyed the conversation. We'll have to talk again once you finish your that study and have that data. That'd be really interesting to follow up and see what you find. So, yeah, appreciate it.
Thank you so much for the opportunity, and I hope that you enjoyed it.
Yeah, thank you. All right. Okay.